We're moving now toward a field of personalized medicine where we use biomarkers to assess responsiveness, and we don't really care what the histology or the origin of the tumor is, because tumors are more alike than different. I have one recent experience that is very instructive. Some years ago, I was asked to see a patient who at the time was in her 90s. She had what appeared to be chronic lymphocytic leukemia, which is an indolent disease, and I didn't worry much about her. The disease had been diagnosed by an outside facility. They had run her flow cytometry. The report was provided, CLL, and she didn't have any symptoms or problems. Every couple of years, I would see her. A few months ago, the patient presented to the emergency room at the local hospital with really rapid downhill deterioration. She had become much more ill. Her hemoglobin was very low. Her platelet count was very low. And she was developing fluid accumulation in the lung. In fact, they had to put a chest tube, a small Pleurex catheter, into her chest so as to drain fluid. She was then about to begin a new treatment called ibrutinib. Ibrutinib is an oral therapy used for CLL. It's a brilliantly effective drug, and I, of course, felt that it would be reasonable. But as I was talking to the patient during our conversation, I said, well, since you have a high circulating white count, since it's not that hard to test you, perhaps we would run your blood and take a look at the drugs and treatments that would be best, particularly if you're not responsive to the ibrutinib. Now, I have to point out here that ibrutinib, the drug, has a response rate that approaches 90%. So the likelihood that she was not going to respond to ibrutinib was small. So we did draw her blood, and we set up the laboratory analysis, and we did very, very good studies. And the results were shocking for me, because ibrutinib was completely ineffective. In fact, I was dumbfounded that a drug that has a 90% response rate didn't seem to be working for this patient. I called a physician who had already prescribed this extremely expensive drug. I think it's $20,000 a month or some extraordinary amount of money. So clearly, with her already filling a prescription and getting ready to start the drug, it seemed hard to argue that she should not take a drug that had a high likelihood of benefit, even though my laboratory tests suggested otherwise. About 10 days ago, I got a phone call from her doctor. She hadn't responded. It turned out it wasn't B-cell CLL at all. It was a T-cell prolymphocytic leukemia, a completely different animal. This was no longer what they thought it was. This was a disease that would not respond to the Bruton tyrosine kinases. It would not respond to ibrutinib. We were right. I was correct. And the drug that I had recommended, and I had the temerity to report as my recommended therapy, despite everything else, was venetoclax. Venetoclax is a drug that has a very specific effect on hematologic malignancies, and it worked like magic. So I think this is an extraordinarily interesting example of the laboratory test being more accurate and more predictive than the diagnostic technologies that were used in this patient's case. We had correctly identified the treatment for a patient contrary to every expectation, contrary to every diagnostic finding, contrary to every clinical guideline. We were right, and they were wrong.